Hi, good evening, everyone. Thank you for joining us. MOASC is really proud to present tonight's webinar, which is going to focus on our GI series. Today, we're going to discuss updates in the management of gastroesophageal cancers, and we have a really distinguished lineup. Dr. Andrew Hendifar, who will be our lead moderator, and we have our two panelists, Dr. Gong from Cedars-Sinai and Dr. Zev Wainberg from UCLA. So I think we're all in for a treat as we learn more about cancers which are rapidly changing in terms of treatment landscape. So I'll send it to you, Dr. Hendifar. Thank you.
Okay, great. So right now on the screen, do you see the panelists and the presentation?
We can see you. Yeah.
Okay, great. All right. Well, thanks everyone for joining. I have the honor and privilege of introducing Dr. Zev Wainberg, who is a professor of medicine at UCLA and co-director of the UCLA GI Oncology program, and Dr. Gong, associate professor of medicine, medical director of colorectal cancer at Cedars-Sinai Medical Center. And today we'll be talking about updates on the management of gastroesophageal cancers. And I got the best picture of Dr. Wainberg I could find. He'll start us off with locally advanced gastroesophageal cancer.
Thanks, Andrew. Yeah, that's a good shot. Thank you for that in the lab coat.
Yeah.
So I'm happy to go over some of the recent data sets in this context. I can't advance the slides, so can you
I got
someone
you.
advance the slides? Okay,
Sure.
to slide 4. So, you know, with the advent of immunotherapy in advanced disease, the questions have been primarily about can we use the drugs as we have been used to doing that work in advanced disease and move them forward in earlier stages of gastroesophageal cancers. I put that group together as we'll talk about. I don't know, Andrew, my slide's not advancing, but I don't know if anybody else can see the slide advancing.
Yeah, it's stuck on the first slide for me too.
Is it?
Yeah.
Let me just reshare
Back
again.
one. Yep. Okay, so this is a study, a very large study, which was just recently published, which tried to move the PD-1 antibody pembrolizumab to into patients who were earlier stage, and it was divided into a few different cohorts. This is the FLOT cohort, and the FLOT is as everybody knows, has been sort of the standard of care for perioperative management of gastric cancer for a few years. And this enrolled patients who were candidates for perioperative treatment, meaning those patients without metastatic disease, these patients with T3 or above tumor staged endoscopically by EUS. And the question is very simple, asking, did pembrolizumab improve outcomes to FLOT? There were a few other cohorts in the study, which in the interest of time, I'm not going to get into today, that asked the same question about perioperative pembrolizumab with 5-FU based chemo. But here this was FLOT, and FLOT is standard of care. So this is the main cohort, which is relevance perhaps for us. Next slide. And so a way to read out and determine if your drug is going to be successful in a perioperative setting is the first thing that's been somewhat validated over the last 5 to 10 years has been pathological response rate. And what in particular the pathological complete response rates is after 2 months of FLOT-based chemotherapy. Andrew, can you advance to the next slide?
Is it getting stuck again?
Yeah. Okay, there. So as you can see, the pathological response rate in this group of patients who got pembrolizumab was significantly more than the group of patients who didn't get pembrolizumab. Now, this included the entire group of patients, both the FLOT cohort and the 5-FU based cohort. You can see the 5-FU based cohort is on the left, the FLOT based cohort, it includes all 500 patients, which is on the right, including both of those. And it did increase the number of patients with a pathological complete response rate from about 2 to about 13% in basically both of the groups. And this was statistically significant. Next slide. But for the event-free survival of the entire cohort, the study did not meet its primary endpoint. And you can see here that the hazard ratio is 0.81, the p-value is 0.0198, it needed to be less than 0.05. There you can see the curves, may separate a little bit, but then kind of come together towards the end, and there really was no consistent statistical advantage from event-free survival. Event-free survival is the recognized regulatory endpoint for perioperative drugs in gastric cancer. You don't need to show overall survival, that's bonus, but you need to show event-free survival, which is basically the same as progression-free survival. And so unfortunately this study did not meet its primary endpoint. Despite showing an increase in pathological response rate, there was no improvement in event-free survival. Next slide. And then when you look at overall survival, you can certainly see towards the end of the curves, these come together with no trend at all in favor of overall survival, which means that even those patients who were exposed to pembrolizumab in the metastatic setting now, in some effect, had just as good an advantage. So there would be no advantage in overall survival to the addition of pembrolizumab in perioperative gastric cancer. Now, next slide. And here you could see that on the left it sort of includes the right includes the entire group, which includes the FLOT cohort. There really was no trend at all to overall survival. Next slide. With respect to safety, I think there was no huge impact on perioperative risk with pembrolizumab, as you can see on slide 9. It does add some toxicity, of course, expected IO toxicities, but no significant impact on the risk of getting patients to an operation with any success. Andrew, you're stuck again?
Jeez.
Oh, there you go. Yeah, maybe keep doing that.
Yeah, I'll just do this. Yeah.
Okay. So here you could see, you do increase some immune-mediated adverse events, but no significant impact on overall survival from a safety perspective. Next slide. So this was disappointing in a little bit because we have pembrolizumab for a long time in metastatic disease. We've known that it has a role, particularly in CPS high patients for metastatic gastric cancer. But what this study failed to meet its endpoint. What is not yet shown and what remains to be seen is whether, if we exclude the CPS 0 patients from that analysis, will the drug have an impact? And that's being looked at now. It may not be a big enough cohort, but ultimately that may be, the theoretical possibility is that this drug may have a role in perioperative disease in the right patients. So now we have the Matterhorn study, which is a much larger study. It's up to almost 1,000 patients, and looks at durvalumab with FLOT versus placebo. And this is asking a little more straightforward question. Number one, the statistics are a little simpler, with event-free survival as the only primary endpoint, not overall survival. With pathological CR and overall survival as secondary endpoints, but asking the question, the same kind of question, is durvalumab plus FLOT better than placebo plus FLOT? And it's all FLOT. So we've eliminated 5-FU platinum from this equation, and we're asking the more contemporary adjuvant perioperative question. Next slide. So the first thing to read out was, again, the pathological response rate, which was also quite dramatically increased from 7 to 19%, both impressively on central review, which we didn't do so much on the first study. But here you can see the pathological complete response rate is quite a bit higher with the addition of durvalumab. So remember, the first part FLOT became a regimen was that it was compared to an old regimen called the MAGIC trial, ECF. And the reason FLOT was felt to be a better perioperative regimen was because it showed a much higher path response rate. So we're taking the history of the value of path response and trying to apply it to these new drugs. Now, on the next slide, slide 12, it goes over some of the even more nuanced pathological information, which just doesn't include just a complete path CR, but also includes a near complete path CR, which is basically a minor residual disease left at the time of surgery. So remember, patients get 2 months of chemo, they go to surgery, they get 2 months of chemo. That's the standard of care for this patient population. We have not been, these studies, I will repeat, do not enroll patients who have radiation. They do not enroll patients with esophageal cancer. They're really for gastric cancer, including some GE junction and to some extent, even maybe Siewert-1 tumors. Next slide. Now, what's interesting here is that one of the endpoints was how many patients, was there any difference in R0 resection between the two groups? There wasn't. You could see 86% of patients in each arm had an R0 resection. All patients handled chemo pretty well. If you look at preoperative treatment, 96, 98% respectively got 2 cycles, which is 4 weeks. And even in the postoperative setting, it goes down a little bit, but it's still close to 70% in both groups. And that's a much higher than was historically demonstrated. So there's not a huge drop-off. There's a little drop-off as expected and from neoadjuvant to adjuvant. But in terms of can this be safely administered, I think the answer is yes. There are efforts to move more treatment up front to answer that question, which is a separate question than was being asked here. Next slide. Safety, I mean, here you did have an increase in some immune-mediated side effects. You did see an increase but no difference in the all-cause grade 3-4 adverse events, which are mostly chemotherapy side effects. Next slide. So if we summarize these two studies, in the Keynote 585, a more complete pathologic response with pembrolizumab did not translate to a benefit with event-free survival and long-term outcomes. Biomarker stuff is still pending. The Matterhorn study does show an increase in pathological response to the checkpoint inhibitor with durvalumab plus FLOT, but we still don't have the results of event-free survival. We're expecting those sometime in 2025. So the idea is there a role for perioperative immunotherapy for gastric cancer? The answer is we're not sure yet. Just because you have an increase in pathological response rate does not mean it has an impact in survival. So to be determined if we're going to add these drugs to perioperative setting. Next slide. So, long-term data is still pending. Again, PD-L1 CPS testing may reveal a group of patients. Next slide. So we do have, and we still have, adjuvant nivolumab. And adjuvant nivolumab has been approved for a few years now based on the Checkmate 577 study for both squamous cell and squamous cell esophageal cancer in patients who get carbotaxol radiation followed by esophagectomy. And that's something that was demonstrated a couple years ago. Next slide. With improving disease-free survival, as you can see on the left, both from a local disease-free survival and metastasis-free survival, which looked at metastatic disease. So in 2 regards, met its endpoint. We don't have information yet on overall survival. That hasn't been presented yet to my knowledge. Next slide. Next slide. We do see here that there is maybe a little benefit from the squamous cell carcinoma subset. Even though it was far smaller than the adenocarcinoma subset, there is a group of patients with squamous cell who may get more bang for your buck from immunotherapy, which is, I think, relatable in the metastatic setting as well. We did not see a huge trend in CPS score as being that important in this study, but it really wasn't looked at that comprehensively the way it was in metastatic disease. And of course, here we have the expected immune-mediated side effects. Next slide. And keep going. So when we look at PD-L1 score here, just to get into a little bit of the weeds, You can see the greater than 1% actually crosses the median, the less than 1% doesn't. So it may be just that the numbers are really, really small. They didn't do a great job in this study looking at PD-L1 scoring. It really wasn't an emphasis. They did look at TPS. You can see that on the top, tumor cell PD-L1, but it hasn't been clear that that affects it in the adjuvant setting. So by and large, the standard of care is, regardless of CPS or TPS, adjuvant nivolumab is indicated after surgery. Next slide. And then let's keep going. One more. So where do we stand for adjuvant nivolumab? We have an answer. I think if you have carbotaxol radiation followed by surgery, you should get adjuvant nivolumab for a year. That is the standard of care based on these curves. The big question is that remains still is number one, what do we do in patients who don't get surgery? What about patients who are not surgical candidates? Should we be giving them immunotherapy? If they're non-metastatic, the answer to that is forthcoming in a large study that is kind of going to read out also next year called Keynote 975, which added pembrolizumab to the definitive chemoradiation. So the question of, if you don't have surgery, what do you do? We don't know yet. We're going to wait and see what the definitive chemoradiation studies will show. A recent head and neck study looking at adjuvant atezolizumab after definitive chemoradiation was negative, but hopefully in esophageal cancer it might be positive. And with respect to perioperative gastric cancer, well, I think for now we're still in a holding pattern, waiting to see if these drugs will work. At ASCO this year, there's going to be very large data sets presenting, which are going to change some of this and also even change how we approach chemoradiation in esophageal cancer, I suspect. So that's my segment on perioperative management. Happy to take questions or questions at the end, whatever Ashkan and Andrew say.
Well, why don't we take some questions now if any audience members have any? I actually have one. And basically that is, what do you think we might see in terms of the biomarker story for neoadjuvant checkpoint inhibitor with chemotherapy for gastric cancer? I mean, do you think that this is going to correlate? Is there any preclinical or I should say smaller studies that have looked at this?
Yes, it's a good question. There was a smaller study called the Dante study, which was done in Germany, a randomized phase 2 study. It did seem to suggest that CPS score mattered when it came to perioperative immunotherapy as well. So it wasn't just a metastatic disease correlate. Where it's very clear is an MSI high. So if you do have an MSI high patient with early stage disease, maybe we'll talk about that a little later, those patients clearly have a role for immunotherapy and maybe not even requiring chemotherapy to some extent. But when it relates to this large group of patients, I think we're going to have to wait to see the subset analyses in these subsequent studies.
Do we know if in either of those studies MSI high patients were identified?
Yes, so there were, and to some extent, they probably should be excluded from these analyses because they could swing your study to be positive even if you don't have enough. All it takes is some of them. So I think that's going to be looked at after the fact. It certainly isn't out for event-free survival, but it was out for pathological response rate, and some of those great path CRs were MSI high patients. Absolutely.
Thank you.
Any personally, I think if you have early stage gastric cancer now, you should strongly consider using those drugs based on all of the collective data that exists in the literature.
Thank you. Any other questions? Okay, we can reserve discussion for later on. Right.
Yeah, we have time for some more. I mean, I'll pick your brain a little bit. So, for what kind of patient would you be concerned about using FLOT, or where would you, if you felt a patient wasn't have the right performance status to receive FLOT, would you give an alternate regimen, or would you just dose reduce or push it? How do you approach the
Yeah, I mean, it's not an easy regimen. I think we know that. It really isn't an easy regimen, FLOT. I mean, it has a lot of cytopenias. It's not a great regimen for the elderly. It's infinitely easier to give it neoadjuvant than adjuvant. So sometimes in practice, I think we all have learned to maybe give a few more cycles of FLOT preoperatively, excuse me, and sort of leave it out on the back end. And I think that's, you know, a standard. I don't want to call it a standard. It's a natural evolution in a difficult regimen. Maybe like pancreatic cancer, we do that as well. But I think as an alternative, I think it's very reasonable to do Capox or Folfox. I mean, if you think that the Taxotere is very difficult. Um, Interestingly, in the different countries, they have adopted FLOT, and so it used to be uh, they didn't want Taxotere either, and then because Taxotere actually has pretty reproducible data in adjuvant gastric cancer in Asia, they've kind of come around a little bit. So um, in a healthy, fit patient, I absolutely prefer FLOT. If I'm really gearing this patient to get to surgery and I don't want to jeopardize that, I think sometimes Folfox is just as good from my end.
So I'm sorry, just to follow up on what you had said before. So if a patient is MSI high with early stage gastric cancer, I mean, you would treat with, I mean, I think they're right. You would treat with neoadjuvant checkpoint therapy, correct? I mean, you would
Yeah, I
avoid.
would. I'm actually pretty comfortable with that. I do it a fair amount off label, but there was a study, the Neonipiga study, that showed like an 80, 90% path CR rate. There was a study, with just checkpoint inhibitors, Ipi/Nivo, or even single agent checkpoint inhibitor, I think in some patients is all you might need. There's all sorts of questions in MSI high patients. Some of them don't need therapy. Some of them just need surgery. Some of them probably don't need surgery and just need immunotherapy. So it's a very it's still a moving target. I think what they probably don't need though is chemo. And so most studies have shown, extrapolating from one study to the other, they do just as well without chemo. And so
Do,
I
do,
try to avoid chemo in the perioperative space for someone with, um, and in the advanced setting if I can, for someone with MSI high gastric cancer.
so do you think we need clinical trials to prove that point, or can we, in the very same vein as what we're seeing with rectal cancers, where we're seeing high response rates with either single or dual checkpoint therapies, where we're even avoiding, surgery in those patients? I mean, can we use a similar
I mean, the
approach
results are
for,
very similar, right? If the results are
right?
very, very similar, if you look at these studies side by side, the rectal cancer, the Starolimab data with some of these other neonipiga studies, or some of these early stage studies in gastric cancer, the results are actually pretty similar. So I feel comfortable with that. I don't know if we need a separate randomized data set. Um, I think that it was very challenging to do those studies nowadays.
Yeah, I would agree. I think my colleagues at our institution for an MSI high cancer uh, stay away from chemotherapy in the perioperative setting.
We have one question. Dr. Wainberg, are there any upcoming promising IO biomarkers in the space, like maybe perhaps aside from CPS and PDL1 and MSI high, anything else that you're seeing there?
I mean, I think all of the biomarkers that are validated in metastatic disease that Jen will talk about are probably worth testing as well in the adjuvant context. I mean, studies are ongoing, I think, with Claudin 18 targeting agents in the perioperative setting. There's also uh, other sort of more immature biomarkers that might be ready to be tested in the adjuvant setting as well, that studies are starting up. So, um, you know, I think it's worth testing that stuff. Those are very, very challenging studies because you need the results in real time before you start perioperative treatment, where, you don't really have by the time you get the data back, it might be patients off to surgery. So it's very hard to actually design those studies in the real world. HER2 studies have shown some suggestion of benefit, but also mixed results. So I think this new wave of HER2 drugs is probably um, certainly going to look at that as well.
Zev, there's also a smaller cohort of EBV positive patients that starting to have a signal that they respond almost like an MSI high, have high PD-L1. So that's kind of an interesting marker to look at as well.
Yeah, I don't know. Are they there? A lot of them are Asian patients, right?
Mhm.
Yeah. So we have a little different biology here, of course, but you know, I think by and large, my personal take is we're going to move eventually in that direction. We're first going to focus on trying to reduce radiation in this disease, which we've already done to some extent, and hopefully will continue to do, and then start expanding systemic options.
All right, that was great. Thank you so much. Let's try to get the next talk teed up here. Let me see if I could do a better job this time. There you go. All right, do you see that?
Yes, I can.
All right.
All right. Well, thank you, Dr. Hendifar, Lashkari, and Dr. Wainberg for having me. I'm going to try to carry on from the perioperative and adjuvant space to now talk about some updates in the metastatic space of esophageal and GEJ cancer, really focusing on some of the FDA recent approvals that could be readily applied to clinic today. Next slide, please. So starting off with esophageal squamous cell, first-line advanced ESCC, Checkmate 648, was a phase 3 study. This was a 3-arm trial, essentially of metastatic ESCC, no prior systemic therapies for advanced disease, randomized, as you can see there, to Nivo plus the chemo backbone of cisplatin and 5-FU, which you'll see is a common kind of backbone used more frequently in Asia than on the West. The second arm was Nivo-Ipi, the dual checkpoint. And then chemotherapy alone was the third arm, co-primary endpoints of OS and PFS. This is a population that we probably don't see as much here as adenocarcinoma, but still wanted to highlight on the right there, the demographics, predominantly an Asian represented study here. I've highlighted the PD-L1 and then just the smoking status on the bottom. A little bit different set of risk factors for this population. Next slide. So in terms of overall response rate on the left here, it was stratified by those that were PD-L1 greater than 1% versus the overall population. Just highlighted there what you're seeing on the response rates with the Nivo plus the chemo backbone versus Nivo-Ipi, which is a little bit lower, and then chemotherapy alone. And on the bottom, I've highlighted median duration of response, where maybe there is some difference for a longer durability of response with the Nivo-Ipi arm compared to the other two arms. The study did meet its primary endpoint, highlighted on the right there. Overall survival greater than 1% was positive, and also in the overall population as well. Next slide. And this is something that we'll kind of touch base later in the adenocarcinoma setting too. A little bit controversial really about what's driving these results. And here, this subgroup was actually buried in the supplements, but as you can see there, as I've highlighted, it really was greater than 1%. About 50% of patients were greater than 1%. And then greater than 10%, actually 2/3 of those were greater than 10%. And as you can see here, the hazard ratio comparisons there. Regardless, the FDA approved the combination in the past 2 years for the chemo plus the nivolumab backbone, as well as a Nivo-Ipi combination as well. And I'll talk a little bit more about that indication coming up. Next slide. And just another study that I wanted to highlight because it recently made its way into the FDA approval and into the NCCN guidelines too. This was a second-line study, advanced ESCC, Rational 302, advanced metastatic ESCC, progression after or during first-line systemic treatment, randomized to the PD-1 inhibitor tislelizumab versus investigator choice of chemotherapy of a taxane or irinotecan, and the primary endpoint was overall survival. And I just highlighted on the bottom there, in terms of the patient demographics, previous therapies, essentially all of them had received prior platinum-based chemotherapy. I mean, this is a little bit important to note as well regarding the label as well. And next slide. So this study did meet its primary endpoint, overall survival benefit, with the PD-1 inhibitor versus investigator choice chemotherapy. The overall response rate was higher too, 20% versus 9.8%. And so this was FDA approved, and the notice came out just a few weeks ago. And I highlighted here, it's for metastatic or unresectable ESCC following prior systemic chemotherapy that did not include a PD-1 or PD-L1 inhibitor. And we can kind of debate, regarding the relevance of this approval, given that a lot of patients probably will get first-line chemo IO in the advanced metastatic ESCC space as well. Next slide. So this is where the NCCN guidelines were recently updated. On the left here is first-line squamous cell carcinoma. And as you can see on the top box there, different from the Asian kind of preferences for cisplatin-based chemotherapy, oxaliplatin is preferred due to lower toxicity here in the West. And if you are using that, there are now category 1 indications for either FOLFOX or CAPOX plus nivolumab, irrespective of PD-L1 status, as you can see I've highlighted there. And then Nivo-IPI on the bottom, which I didn't highlight, based on this approval, has a category 2A recommendation. On the right is the second line and subsequent therapies. You can see there tislelizumab made its way into a category 1 in the second line space. But again, I think this is probably going to be in smaller use, but the label is there for this PD-1 inhibitor in the population not previously treated with PD-1 in the first line. Next slide. And now I'm going to kind of jump into the adenocarcinoma space, mainly esophageal and GEJ adenocarcinoma. But this was Keynote 590. This was the pembrolizumab entry into the ESCC world as well. This was a randomized phase 3 trial, first-line metastatic adenocarcinoma or squamous cell of the esophagus or CWORT1 GEJ adenocarcinoma. It was combined pembrolizumab plus chemotherapy, which was 5-fluorouracil, and again cisplatin every 3 weeks. And I've juxtaposed these survival curves. On the top is esophageal squamous cell. As you can see there, in the overall population, it was positive for overall survival, and then enriched with the PD-L1 greater than 10 on the top left there, and then the overall cohort on the bottom as well. You can see there's a survival benefit. But if you look at the baseline characteristics, 73% were squamous cell carcinoma, and only 27% were adenocarcinomas of the esophagus or GEJ. But as you can see there, PD-L1 CPS of greater than 10 comprised 50% of the population, 52% in the chemotherapy alone. And on a post hoc analysis, the authors, investigators looked at a PD-L1 subgroup less than 10. And as you can see there, the survival differences were attenuated, 10.5 versus 10.6 with the chemo IO backbone. Next slide. And checkmark 649 was nivolumab's entry into the first-line advanced esophageal and GEJ adenocarcinoma, randomized phase 3 trial, first line again, now using more of what we kind of are familiar with, CAPOX or FOLFOX backbone plus nivolumab versus chemotherapy alone. The overall subset is on the top there, and the PD-L1 CPS greater than or equal to 5 subset is on the bottom. In both cases, chemo plus nivolumab was superior to chemotherapy alone. If you look at potential drivers of these differences, you see that gastric cancer comprised 70%, GEJ adeno was 17%, and esophageal adeno was only 13 versus 14%. Here, PD-L1 CPS greater than or equal to 5 comprised about 60% of the patient populations in both arms. Next slide. And so both of these kind of pivotal phase 3 studies led to respective first-line approvals for chemo plus pembro, platinum backbone, and chemo plus nivolumab in esophageal or GEJ cancer. Of note, all of these first-line FDA approvals of chemoimmunotherapy are irrespective of PD-L1 status, so a more looser label, but we'll talk a little more about the indications of this and what this means a little later on. Next slide, please. And just a brief entry discussion about HER2 positive. This is really focused on GJ, esophageal adenocarcinoma. First line Keynote 811. This essentially was comparing platinum-based chemo plus trastuzumab versus platinum-based chemo plus trastuzumab plus pembrolizumab. And these were initial results on the left. Overall response rates, as you can see, they're higher than the trastuzumab chemo alone backbone. You can see the survival differences in the middle there. And initially, the label for this was actually irrespective of PD-L1 status as well. And there was a lot of retrospective data that showed that if you were HER2 positive, you were majority of the time going to be PD-L1 positive as well. And in this population, 85% had a PD-L1 positivity of greater than or equal to 1. There was some signal of difference in OS in those who are PD-L1 positive. And on a post-hoc analysis, no differences in PFS for PD-L1 less than 1. And as a result of these kind of longer follow-up secondary analyses, the FDA ultimately revised their label now to limit those with HER2 positive metastatic GC and GEJ cancer to those that are not only HER2 positive, but with the PD-L1 CPS greater than or equal to 1. So this was a recent amendment to the label. Again, previously, irrespective of PD-L1 status, was the former labeled indication. Next slide. And so there was, as you can imagine, there was a couple of different studies having very different kind of PD-L1 cutoffs. CPS of 10 was driving a lot of the Keynote 590 with the chemo pembro cohort. CheckMate 649 had a PD-L1 cutoff of CPS of 5 or higher for the chemo nivo cohort. And then Keynote 811, initially irrespective of PD-L1, but then they amended their label to PD-L1 greater than 1 as well. So I think it was pretty timely that Keynote 859 came out. This was a randomized phase 3 trial enrolling HER2 negative first-line advanced gastric or GJ adenocarcinoma. Again, it was a platinum-based chemotherapy plus pembrolizumab versus chemotherapy alone. And the survival curves are seen on the left, the ITT on the top, the greater than or equal to 1 PD-L1 CPS subgroup in the middle, and those greater than or equal to 10 on the bottom. If you look at how the patient population characteristics played out, the majority were gastric adenocarcinoma, over 80%, and only about 20% or so were GEJ on both arms. But you can see that the PD-L1 CPS greater than or equal to 1 comprised nearly 80% of the population versus 35% with that greater than or equal to 10. And if you go to the next slide, please. I think it was nice here to have the subgroup where there was a little bit more granularity with PD-L1 cutoffs in this kind of phase 3 study, where you can actually see that the hazard ratios become lower with the greater than or equal to 10 subset. But actually, if you look at the 1 to 9, and then if you actually just look at greater than or equal to 1, there was a favoring for the chemo pembro arm versus the chemotherapy alone arm there. The hazard ratio was a little bit lower than 1 for the less than 1, but again, across the 1 there, as you can see, which didn't reach significance. And this resulted in the FDA approving in HER2 negative just last year, chemo backbone of platinum-based chemotherapy plus pembrolizumab for the first-line treatment of metastatic HER2 negative GJ adenocarcinoma. And this really was kind of an entry into the gastric realm for the pembrolizumab label in this population. Next slide. So here in the HER2 positive space, really it's category 1 for PD-L1 greater than or equal to 1 for HER2 plus pembrolizumab and chemotherapy. But really in the middle there is where the HER2 negative population is, and it's a little bit different based on your regimen of choice. If it's FOLFOX or CAPOX plus Nivo, they still have category 1 for a PD-L1 CPS of greater than or equal to 5, but the cutoff becomes PD-L1 greater than or equal to 1 for using pembrolizumab. So a little bit of some confusion there depending on the choice of IO that you use, and I think this is a little bit hotly debated right now whether you what's the actual PD-L1 cutoff based on the compound and what kind of tumor type that you have. I think the recent Keynote study shows that maybe you don't need as high as 10, and maybe you don't even need as high as 5. You might just need greater than or equal to 1 as that kind of cutoff to use chemo IO. But I think a lot more data is showing that chemo IO probably isn't really for all comers, including those that are negative or 0. Next slide. And this is just a little bit of a table for the second line, which I'm not going to go into too much. And I think that's pretty much it for my part.
Oh, that's funny. I'll never get sick of this slide. All right, let me get out of share mode. All right, thank you for that excellent talk. So any questions from the audience or from Dr. Lashkari?
Yeah, I had a quick question, and that was, regarding patients with, let's say, HER2 positive um, GE junctional or gastric cancer. Are studies looking at treating these patients with frontline interventions without chemotherapy? Let's say if they have a high CPS score, giving HER2 directed therapy plus a checkpoint therapy, to compare versus, uh, the whole shebang, if you will, chemotherapy, IO, and HER2 directed treatment. In situations like that, could we potentially get as much or more from just a checkpoint therapy and HER2 directed therapy?
So there was phase 2 data by Dr. Janjigian's group where it was kind of a prelude to the Keynote 811. They interestingly had a lead-in of just the HER2 plus the IO before adding the chemotherapy. And I think that's really the most published data. There hasn't been a formal phase 3 trial looking into that. There was a signal of activity in that lead-in phase 2, which was kind of interesting. But I think it's still, considered the need for investigation rather than standard of care currently.
So I have a few questions for the whole panel because you guys are the ones I always call if I have a question on these types of cancers. So do you ever use 5-FU cisplatin anymore? And if so, in what situation?
I don't.
I don't either. I think there have been non-inferiority studies done with FOLFOX where it's just same efficacy, less toxicity, basically. So don't use 5-FU cis personally.
Okay, that's good to know. And then I have a question for everyone. When was the last time you omitted IO for a gastric cancer patient or esophageal cancer patient, and why did you decide to do that?
I mean, personally, I've omitted it in CPS 0 patients. I mean, I just don't feel like it adds anything at all in that patient population. And I mean, Jen pointed out the studies, and then there have been many meta-analyses now where they've looked at all this data and pretty comprehensively. And I think the CPS 0 patients just don't get any benefit. You could argue about, you know, giving it for a CPS 1 through 5, because I think there you could maybe convince yourself that the assay maybe wasn't great and maybe you didn't have a great score. But I think for the real CPS zeros, if you trust your pathologist, I don't give it there, even though it's FDA approved. So I mean, I think
How about
that's
you, Dr.
kind
G?
of
No, I was actually guilty before of using it when the label came out. It was kind of all comers, but I realized, with the increasing data, I agree, zeros probably not. And especially if you had a trial that would have a second or third line IO, we probably would save that for the clinical trial instead.
Yeah, I think you guys give good advice. I mean, the last time I gave IO to a CPS, probably unsuitable patient, I got a pretty bad autoimmune colitis out of the result of it. So I think that's really good advice for our viewers and listeners. Okay, great. And then I had one more question that was on the tip of my tongue. All right, well, we'll just go on. If there's any other questions, we'll go on to the case presentations. Anything else? Okay. And I like the group chat. So if anyone wants to participate through the group chat, even responding to these case presentations, that'd be nice. All right. So let me share my screen. I got a chuckle. All right, it's Dr. Mike. He's an Instagram doctor, if you didn't know. Okay, first case. I call this a tweener. So it's a true story. It's a 55-year-old gentleman. He presented with chest pain to the ER. He got a workup, and on EGD, they found an adenocarcinoma at 39 centimeters. An EUS showed that it was a T3 lesion. He also had a colonoscopy, which showed only a tubular adenoma, very clean. He has a pretty extensive family history. His father had prostate cancer and kidney cancer, and his mother had breast cancer at the age of 40. Okay, so here is the molecular testing on his tumor. But I'm not hiding anything, and I'm not trying to trick anyone. So the CPS was recorded as between 3 to 5, HER2 negative. The MSI was called intermediate, and the TMB was 10. On IHC, there was a loss of loss of MSH2 and MSH6. And on somatic sequencing and germline sequencing, he has an MSH2 abnormality consistent with Lynch syndrome. All right.
I mean, I
Dr.
think,
Wainberg and Dr.
yeah.
Gong, take it
So,
away.
I mean, these are tough calls. I mean, if it's Lynch syndrome and microsatellite unstable, and I also will say that I've seen some patients who I want to clear this with the geneticists, but if they say, hey, this is a real microsatellite unstable tumor, and I would probably still treat without chemo in this patient. I would either give Ipi-Nivo, which has been my first choice based on that Neonipiga study, and that's how I would probably approach this kind of patient.
Ipi-Nivo, okay. Dr. Gong, any thoughts on this one?
Yeah, I agree with Dr. Weinberg. I think if it was a true Lynch syndrome, we've used Nivo-Ipi in a little bit more frail patients. We even use single agent pembrolizumab in the perioperative space. I thought it was interesting, Dr. Hendifar, that despite the germline mutations, there wasn't that many other mutational load. The TMB was about 10, and I think that's a little bit confusing in terms of what's the kind of response in this kind of population for immunotherapy. So in these, I've also used on the flip side, and Dr. Weinberg talked about some data about that too with chemo IO. They did include some MSI high patients in those studies, and on subgroup, although it's very small, their PCR rates did seem to be higher than those of just MSS as well. So I've similarly used sometimes when I feel concerned about the response, I've added a chemo backbone to IO as well.
Yeah, I mean, I've had several patients who have Lynch syndrome but then have tumors that are not Lynch associated. So I had a hard time with this particular tumor because, like you said, the MSI was intermediate, the TMB was only 10, and I was just generally nervous to give IO alone. So I would take the chicken way out. I gave him chemoimmunotherapy. I gave both. I said I'll cover both bases. So 4 cycles of FOLFOX Nivo. Patient underwent had a surgery. It's invasive adenocarcinoma, moderately differentiated, intestinal type, 1 out of 18 nodes, and absolutely no evidence of treatment response. So I gave only a single agent immune therapy, and I gave chemo, and there was no response on path. What would you recommend at this point? And I asked you both this actually about this case
I
while
don't
I
know
was
if I
treating.
probably not going to say the same thing I said then, but
It's okay.
I said number one, I actually think I would recheck this tumor, to be honest with you, with PCR. I am curious if this is, like you said, maybe this is an MSI high, a Lynch syndrome patient who has a microsatellite stable tumor. And just like you, I've had a bunch of these patients. In fact, I have one right now, and I have 2 right now actually, who they have a Lynch syndrome piece of paper, and then I biopsy the tumor, and turns out it's not convincingly Lynch, or it's not convincingly microsatellite unstable. And I think there is actually a growing literature here that these patients are out there, that the patients with Lynch syndrome are both at increased risk of getting Lynch-associated cancers and at increased risk of getting sporadic cancers, interestingly. And so what I would do with this patient, just on the sequencing level, is see what came out of the actual specimen, and even perform PCR, which we don't do a whole lot of, as you
Gotta do
know.
the PCR. That's a great point.
Just because you can do that now with some normal
Yeah, it's just easy.
Tissue. But let's say the patient's, which one which one should we comment on, Andrew? If he's MSI or if he's MSS?
You do the PCR and he's MSS.
So I would continue FLOT. Probably not IO anymore. I would probably say this is a bad MSS tumor. I would just do FLOT. Now, the reason I would do that is that despite that lack of pathological response, there's not a better option out there. And this was actually looked at in a randomized phase 2 study, which was presented last year, called the Vestige study. And what they did is they took patients, gave them FLOT, and then if they didn't have an adequate pathological response, as this patient, they randomized them to either continue FLOT or switch them to some IO combination, and they did better on FLOT. So the idea, you're going to salvage this patient by switching gears to some IO-based combination, hasn't been, at least in that study, wasn't borne out. And so I think we're stuck with that patient, and I would probably personally continue the FLOT.
And when you, like in our multidisciplinary conferences, we actually have to talk, the team down from over-interpreting poor path responses, because we just don't have the data to really guide management. Do you find yourself in the same situation?
Yeah, I mean, I think we all try to balance our pathologists, and I think here the truth is you don't know what that patient's number of lymphadenopathy was before,
Right.
And so I find it to be useful if it's really positive, and not that useful if it's very negative, personally.
Beautiful.
That's my
Okay.
thought. I don't know what John thinks about that.
I completely agree. We stick to the script. We say continue the chemo. And I've had some patients who had really good responses on path review, and they relapse, and then I've had several who had poor to no treatment response, and they're still doing great, like years out. It really makes me wonder, how reliable predictor that treatment response is.
Yeah, I mean, I will point out, if this patient's truly MSI high, Andrew, then I would probably consider it be Nivo, actually, because
over Nivo.
Yeah, I mean, there I would probably say, hey, maybe this is a patient who might benefit from double immune blockade here, and you kind of have some support in the literature for that based on those studies we discussed earlier.
Excellent. And then I emphasize, he has Lynch syndrome, so we have to start getting to work on his other cancers. Thankfully, he's close to a year out and he's disease-free, so that's good. And you see, I'm going to go back to the panel and see. Let's go back to the chat if there's any other questions. No other questions from the chat. Okay. So I'll finish up with this one. So this was a 60-year-old gentleman with a poorly differentiated adenocarcinoma of the esophagus. It was from 37 to 33 cms. It was near obstructing. Of course, he presented with difficulty tolerating oral intake. He had a PET scan that showed some avidity in the gastrohepatic lymph nodes. And he was treated at an outside institution, and he received carbotaxol with radiation to 50 gray. And the left is the pre-treatment, and the right is the post. So on the pre-treatment versus post, the PET was read as of excellent response, but perhaps a new liver lesion here. So what ended up happening is we reviewed it in tumor board. We thought the liver lesion was probably just radiation effect. And so I wanted to keep you guys with all the right info. So from what we could tell on cross-sectional imaging, that there was no liver metastasis, that the patient had an excellent response to chemoradiation. So what would you recommend that we do next? Dr. Gong, I'll get you to take this one.
I would most likely have a endoscopic confirmation of residual disease as well. Standard of care, should be still to proceed with surgery. There is some recent data from the SANL trial, which is quite interesting, but they had to have confirmed, PCRs with both endoscopy and imaging as well.
Can you go back to the path information, Andrew?
Yeah, of course.
Yeah. So, I think the challenge is that, you're starting out with a poorly differentiated adenocarcinoma. And poorly differentiated adenocarcinoma does have a tendency to recur without surgery. And so if the question is, can we avoid surgery? Is that what the question is?
I'd love hearing you think your way through it. So no specific question.
I think that, we might be headed in the not too distant future to non-operative management for select patients with esophageal cancer. I kind of feel like we might be headed there. It's going to take a little more information and a lot more data, like the way rectal cancer has sort of evolved into this. You can select patients that have complete, clinical responses defined as PET scans and endoscopies, as Jun pointed out, and try to see if you can, avoid surgery. Not saying, I don't think we're there yet, personally.
No, thank you for that. So in this case, we did proceed with surgery, and here it is. It was a smaller size tumor after the treatment effect, partial response of 2 out of 56 nodes, and the CPS score on this tumor was 10. This might be an easy one for you guys, but what do you think?
Yeah, I think this is a pretty straightforward indication to give Nivo based on the Checkmate 577 study. I don't think there's any sort of question that the question is, can you, there is some ideas about should you add chemo to that? I don't think so. There's no real evidence. We haven't had a study that's been positive for chemo in that setting after receiving carbotaxol radiation. So for right now, I think Nivo is the right move.
Dr. G?
Agreed.
Well, great.
I was going to say, and I was thinking about the perioperative, because I think we're a few years away from, at least in squamous cells, maybe if someone has a complete response endoscopically and clinically, they're doing those trials now, we'll be able to leave out esophageal surgery, which that would be a huge move in the field if we can get to that place where we are in rectal cancer. And I think for squamous cells, at least, we might be headed there one day.
Well, what a perfect way to end the hour. Any final words from any of our panelists or Dr. Lashkari?
Thank you. This was a fantastic discussion.
Yeah, you guys, this was great. Thank you so much for all the work and effort in putting the presentation together. The hour flew by. Can't believe it's over.
Have a good night.
Especially-
evening,
Thanks for
everyone.
having us.
Yeah,
Bye.
thank you to all of you. Thank you, Dr. Hendifar, for moderating. This was wonderful.
Great job.
Yes,
Pleasure.
thanks, Dr. Hendifar.
See
Pleasure,
y'all.
guys. All right, see you.
Thank
Be
you,
careful.
everyone.
Bye.
Good
Thank you.
night.
Bye-bye.